We are pleased to provide the video recordings of Florida Digestive Diseases update held on December 4th and 5th, 2021 in Orlando, Florida. This is the video recording from Session 4, all about the colon. The session featured a lecture on performing quality colonoscopy and tricks to always reach the cecum and ways to improve your adenoma detection rate, both by Dr. Douglas Rex. This was followed by a lecture on cold snare polypectomy. Are There Any Limits by Dr. David Johnson. Lastly, a lecture on fecal microbiota transplantation, the present and future by Dr. Darrell Pardi. The session was concluded by case presentations and discussion by Dr. Jiyoung Bang. Please enjoy the session.
I have a similar problem as I did with Dave Johnson in introducing Doug Rex. He is not only one of my heroes, he's also been a friend of mine for a very, very long time. We went to medical school together. We went to internal medicine together. We did GI together, all at Indiana University. I was on faculty there for 8 years with Doug, and so I know him well, and I've followed his career very closely, obviously, and it's just incredible the career that he's had. He's a past president of the ACG. He's current president of the ASGE. I have no idea how anybody finds the energy to lead two different societies, but Doug has it. He is an authority on everything colon, nationally and internationally. He's an unbelievably good speaker, and because he's got so much energy, we've asked him actually to give 2 talks. So I'll introduce both talks, Doug, and the first one is performing quality colonoscopy and tricks for getting to the cecum, to reach the cecum. The second thing that he'll talk about is ways to improve your adenoma detection rate. So Doug, welcome. He's professor of medicine at Indiana University and has a named professorship there, and just welcome,
I'm going to have to cut you off now,
Great
Rob.
to have you. Yeah, cut me off.
That's it. I've been cutting him off for years. Since medical school. Here we go again. No, it's thank you for that nice introduction, and appreciate the opportunity to be here. And congratulations to Rob and Shyam for putting together such a fabulous group of gastroenterologists to take care of patients here in Florida. So I am going to talk first of all about difficult insertion. So what I'll relate to you comes from my own experience in more than 970 patients who have had prior incomplete colonoscopies, either by a GI doc or a surgeon. That's about half of the published literature. And the success rate for cecal intubation is 97.3%, which is numerically higher than the collective literature on balloon enteroscopes. And I think an advantage of the methods that I'll show you for really difficult colons is that you can use them with the tools that you have currently in your endo unit. We currently encourage our referring physicians, if they have an incomplete colonoscopy, to either repeat it themselves or send the patient directly for another colonoscopy and not use BE or CTC, because in our experience, the sensitivity for polyp detection of the radiographic techniques is so poor. I think if the only clinical question is whether there's cancer in the proximal colon, then CTC might be okay. These are our publications on prior incomplete colonoscopy. And with regard to this last one, this is the sensitivity of CTC and barium enema on a per patient and per polyp basis, and you can see that it's abysmal. And these colons are complicated, and I think that the same issues that we have with them, they create the same challenges for radiologists. So in general, better to try again with colonoscopy. So when we have a referral like this, the first thing that we do is classify the anatomic problem, and the overwhelming majority of patients have either a redundant colon or a narrowed angulated sigmoid. About 2/3 a redundant colon and about 1/3 narrowed angulated sigmoid. There's a small percentage of patients who have hernias. If it's a left inguinal hernia, you can basically always deal with that by reducing it manually and then just keeping a hand over it until you're past it. Transverse colon hernias can be a real problem because they can be very difficult to reduce and to even tell when they're reduced. But if you get up to the entry point of a transverse colon hernia, you may be able to get into it, but you won't be able to get out of it if it's not reduce. And I've seen a few patients there. The only way we could scope them was after surgical repair of the hernia. So these are the two major causes of difficult colonoscopy. A redundant colon, a lot of these patients are very big, but sometimes they're just variations in normal anatomy. So the approach here is to choose a standard adult scope. I think many times people think that for challenging colonoscopy, you always want to have a pediatric scope, but thinner scopes are really appropriate for difficult sigmoids. And then key to go underwater, and you want to have an overtube around for occasional use. In the narrow angulated sigmoid, you want skinnier scopes, occasionally a scope that has a shorter bending section on it because it has a tighter turning radius that'll allow you to go around a very difficult angle, and again, water immersion. So in the narrow angulated sigmoid, we usually start off with a pediatric colonoscope. If that doesn't work, we go to the ultra slim, but sometimes one needs an upper endoscope or the push enteroscope. So why water? Well, in the redundant colon, what happens when you insufflate gas is that the colon gets longer. The problem here, as we all know, is you tend to run out of scope when you get up to the transverse or the hepatic flexure. And many of these colons are also dilated, and so when you fill them with gas, they get bigger. You use more scope as you go around each turn. When you fill the colon with water, the sigmoid lies down in a straight line and the colon stays less descended. So when you get over to the right colon, you're not out of scope and you can get into the cecum much more often. In the angulated sigmoid, same thing, you lie it down straight, and the other thing is that prevents barotrauma. Patients who develop barotrauma during colonoscopy, it's very rare, but they invariably will have a complicated sigmoid colon with diverticular disease. And what happens is that as you get into that sigmoid and you're pumping gas, if they have a competent ileocecal valve, they'll trap gas between the ileocecal valve and the sigmoid, and they may perforate. And they'll perforate before you get to the right colon. So I tell all my fellows, every time you enter a complicated sigmoid colon with diverticular disease, switch to water. So two benefits of water in the angulated sigmoid. So on the left here, we have the pediatric colonoscope, 11.5 millimeters, and then the ultra thin and the upper scope, 9.5 millimeters, so a 2 millimeter reduction in diameter. But remember, it's the surface area, pi r squared, that matters, so a significant reduction in surface area. And then in the far right, the SIF 180 push enteroscope, 9.2 millimeters. So thinner is important in an angulated sigmoid. And the other thing is sometimes you need that tight turning radius. So on the left, we have the pediatric colonoscope and the ultra thin, and you can see the bending section is longer and the turning radius is wider. On the right, the SIF 180 and the upper scope. So sometimes, we use an upper scope, but you can run out of scope trying to get to the cecum. Nice to use for therapeutics. The SIF 180 has enough length to get through, but more difficult to use because harder sometimes to get the instruments through. I think it's incredibly important in angulated sigmoids to be able to have superb control of the tip deflection. And to do it best, I think you need to be able to operate the up, down, and the right, left control simultaneously. I do this with what I call the left-hand scope grip. You put the scope insertion tube between your fourth and fifth fingers of your left hand. This frees up your right hand to run the right-left control, your left hand to run the up-down dial, and then you use your forearm to push the scope in. You've got to be able to hold the tip of the scope into a very tight turn and negotiate that turn. So if you could start that video, please. So here is, would you start that video, please? There you go. So here you can put torque on the instrument if you like, and then pin it between your fourth and fifth fingers. And at that point, then you're free to operate both controls, and that's how you get the maximum control. And then start that video for me if you would. So here we are in a patient referred with a very angulated sigmoid. You can see we're using a thinner scope. And you want to keep your hands back about 10 to 15 centimeters from the patient's bottom so that when you push forward with your left forearm to keep the tip of the scope in that turn, you've got a little bit of room to move. A very common mistake is to put your hands right up on the patient's buttocks, and then you can't go forward with that arm pressure as you're pushing. So you've got to slide back. You can easily take your right hand off the control, go back to the insertion tube, and then go back to this left-hand scope grip. And then we're pumping water just continuously. The foot's just on the pedal, pumping water in order to fill the lumen of the sigmoid colon. Again, we're avoiding air both to make it lie down a little bit straighter, to avoid distension, and then just very patiently, very slow movements, trying to find the lumen around the next turn. Once we see that luminal opening, then we've got to keep forward pressure on the tip in order to steer it through. I think the cause of almost all of these is severe diverticular disease. Many of them are very tight endoscopically, and the patient can still be asymptomatic. But in the absence of tumor, if you have a thin enough scope, sometimes a short bending section, and you use patience, you can almost always get through these. And then, of course, once you're through, then it's usually a free ride to the cecum. You may need some abdominal pressure because you've got a floppy scope. Not very good prep in this particular instance, but now you can see we're in a more open section of the colon. So those are the keys there. In a redundant colon, occasionally you need an overtube. That black overtube is the old Olympus reusable overtube. The white one, and I don't have any association with this company, is the Neptune Pathfinder. And in my experience, this is the best overtube that I've seen for colonoscopy. I usually put this in. Obviously, these are redundant colons, not narrowed sigmoids. So put it in with the adult scope and use the long version of this overtube. You still may not be able to get to the cecum. And I don't do this up front, but only usually if I've failed to reach the cecum using the adult scope and water filling. And then sometimes use it to launch an enteroscope. So get it up, get it in place, stiff, pull the colonoscope out, and go up with an enteroscope. So we're still going to have to use special tools. So what am I going to rely on when we get stuck? Well, it's absolutely critical, of course, that we use good loop reduction. That's the essential tool of all safe, comfortable, fast colonoscopy, is getting the loops out. Then we've got sort of two adjuncts. One is abdominal pressure, and the other is position change. MEI studies, the UPD or scope guide studies, show that actually abdominal pressure tends to be less effective on average than position change. But I'm going to admit that I have largely abandoned position change for one reason only, and that's that we're sedating patients with propofol. And once we move them onto their back, the supine position, or the right lateral decubitus position, we're concerned about reflux and aspiration. So we tend to leave them left lateral and rely more on abdominal pressure. So I do think it's important to know about loops as a concept. I teach the fellows about this because I think they need to know how complex loops can become, and that alpha loops and reverse alpha loops are going to be reduced by different directions of torque on withdrawal. Having said that, in clinical practice, I don't use the UPD at all, the scope guide device, and we feel the direction to unwind the scope. So sometimes you need to rotate clockwise, sometimes counterclockwise, and you have to feel if that loop is getting tighter, and if it is, you know you're going the wrong direction. You need to unwind it the other way. I think sometimes we have to create loops in the colon, just like sometimes, or bends and turns in the scope, sometimes like we have to do slide by. Abdominal pressure, I think, is an art form. I try to get my techs to be able to see the monitor so that they can see whether what they're doing is effective. Remember that the best use of pressure is to prevent loop formation. So if you have a loop, you want to take the loop out and then apply the pressure to try to keep the loop from forming. After you've passed the turn, then take the pressure off, because continued abdominal pressure can keep the scope tip from moving forward. It gives your techs a break so that they're less likely to develop injury. Remember that pressure, people often want to push straight toward the back, but oftentimes pressure is best applied with some additional direction. Each position and direction for pressure should only be tried once, and if you feel a loop in the scope, it's best to remove it and then put the pressure there. So here's some directions that can be useful to counter sigmoid pressure. Hand in the right lower quadrant pushing toward the midline. In the upper left, to move across the transverse colon, pressure in the left upper quadrant directed toward the midline to counter transverse looping. 2 hands in the lower abdomen pushing up as well as back, and then to get into the cecum, pushing in the right flank toward the midline. So remember, you got to try different things, and sometimes your tech may not know different combinations of pressure to try but you can suggest these to them. The floppier the scope you have, the more likely you're going to need pressure. And in the very redundant colons, sometimes we'll have 4 or 6 hands on the abdomen. Many of these people are very large people, and it can require that much pressure. I often have people try to massage the abdomen. Kneading may be a better word. You're trying for some manipulation of the abdomen to catch the side of the scope and push on a loop and move the tip forward. Classic position changes, left lateral decubitus is where we usually start, but there are literatures on starting in the supine or prone position, crossing the transverse, rotation to supine. Probably the most reliable position change in colonoscopy is to go from supine to right lateral decubitus when you want to get from above the ileocecal valve down into the cecum. But as I mentioned, I, for the most part, don't use position change very much and have really relied on abdominal pressure. Last step is record the methods that you use to achieve cecal intubation, because the next time you scope the patient, the same anatomic difficulties are going to be there, and you want to go straight to the method that you used that was ultimately effective. So to summarize, you want to classify the anatomic problem, choose the right scope, do the insertions underwater, good basic technique, loop reduction, optimize steering in angulated colons. You've got to have control of right, left, and up, down simultaneously. For redundant colons, a lot of abdominal pressure, have an overtube available. Sometimes it will rescue the situation, and understand the art of abdominal pressure. And that's the end of talk 1. Thank you. If you could put the other slides up for me, thanks. Okay, so we're going to shift gears entirely now and talk about detection in colonoscopy. And you guys ready? Great, thank you. Okay, so the adenoma detection rate. So we all know that colonoscopy is very operator dependent. This was really first established for detection. I think we talk about it still for detection more than any other area of colonoscopy. And part of this variability is just because there's a lot of very subtle precancerous disease in the colon, both for the conventional adenomas and for the serrated lesions. So we've seen large variation in the detection of both groups of lesions, and this has a really important impact. It results in variation in the detection or the prevention of cancer, which is the goal of the procedure. So obviously it's very important. I want to say a word about serrated lesions. I feel that people often think serrated lesions are more dangerous than conventional adenomas. They do account for a disproportionate fraction of interval cancers, cancers that occur after colonoscopy. But it's not true that individual serrated lesions are more dangerous. I have only a handful of videos of serrated lesions with cancer in them, but tons of videos of adenomas with cancers in them. And for any given size of lesions, cancer is more common in conventional adenomas by a factor of 7 compared to serrated lesions. So the problem is not that they're individually dangerous, but that we miss them more often. I went through an exercise I just had accepted for publication. Something that we do in the unit occasionally is allow the fellow to examine completely the colon by themselves. I actually leave the room, and then they drive back into the cecum, and I come back and repeat the examination. And so in 100 tandem examinations with my fellows during the first exam, they missed about 30% of the conventional adenomas, about what you'd expect, and almost all of the serrated lesions, regardless of size, 90% of the serrated lesions. So I think it takes longer to be able to recognize serrated lesions. And when we do colonoscopy, we have to appreciate the subtlety, the range of appearances of these lesions. So as you go across this slide from left to right on the top and then the bottom, you see serrated lesions that are progressively more difficult to detect. In the bottom middle, a lesion that is a true Paris 2B lesion. It's virtually flat. I think almost all the true 2B lesions in the colon are serrated lesions. On the right, an SSL that has a little lump of cytological dysplasia in there. And a lot of people worry that when this is seen, that people resect the part that is dysplastic because it looks like an adenoma and it's easy to see, but don't get the rest of the lesion, which extends out to where the arrows are. So high-level detection assumes that we have a good understanding of this range of disease. So if you could start both of those videos. On the left, we have what I would call an ultra-flat adenoma, and on the right, an ultra-flat serrated lesion, and you can sort of test yourself as whether you can see them. The adenoma is becoming pretty clear. It's visible there in NBI. Obviously, it's going to become clearer when it's injected. On the right, a very subtle serrated lesion, and again, probably completely a 2B lesion. But I just, again, point out that we have to kind of come to the procedure with an awareness of how subtle these lesions are. So how high should we get on the adenoma detection rate? That's the measure of how good we are, and I think the evidence suggests that we should be aspiring to about 50%. That's about the level where interval cancers tend to reach their nadir, getting them as close to zero as we can get them. So we talk about a minimum threshold of 25%. If you're below that, probably some remedial work needs to be done. But even if you're above that, you probably should be striving to get as close to 50% as you can. If you're working in a fit positive population, you need to be about 15 to 20% higher for both the minimum acceptable and the aspirational thresholds. What about a serrated target? Because the adenoma detection rate does not include serrated lesions. It's only conventional adenomas. I personally have been opposed to creating a national detection target for serrated lesions because it's very important when you create a detection target that it actually works in practice, that it doesn't fall apart and it works the same for everybody. And the problem here is that detection of SSLs is dependent not only on you, but on your pathologist. And we all have been seeing over the last decade our pathologists calling more and more serrated class lesions SSLs and fewer of them hyperplastic lesions. But I think that that's a challenge for creating a national target. You can measure it in your institution using the range of detection among your endoscopists to set minimum acceptable and aspirational targets. I would say probably in screening populations about 7 to 8% is a good minimum for SSLs, and 15 to 20% may be where the aspirational target should be. Withdrawal time. Withdrawal time is probably going to get longer. Minimum acceptable withdrawal times in the next version of recommendations. We've got a couple of lines of evidence that optimal technique takes about 8 to 9 minutes to apply. And this has been shown both for prevention of cancer and for detection of serrated lesions, the latter in the New Hampshire registry. So reaching high-level detection, basically, you can get very high without having any special tools. You come at the procedure knowing what you're looking for, and then secondly, you apply good basic technique. High-definition white light, meticulous examination, split or same-day preps, reporting has been shown to be effective. The basics of technique are very simple. Look behind the folds, clean up, and distend adequately. If you could start that video. So here's an examination of the right colon. We did a study a number of years ago where I videotaped my partners doing colonoscopy without their knowledge, and then started videotaping them, but told them I was videotaping them, but I didn't tell them I'd already been doing it. Then we took all the videotapes, mixed them up, reviewed them blindly, and as soon as the videotaping started, everybody did all of the basics much better. They looked behind folds better. They distended the colon better. They cleaned up better. So I don't think this is rocket science. I think we all know what to do. For some people, they get away because the prevalence of disease is fairly low with not doing it carefully. But I think we are doing best when we sort of approach it with an obsessive, compulsive approach. We're trying to probe the tip of that scope between every set of haustral folds on all sides of the colon. The right colon we examine twice now because we have good evidence that more interval cancers occur on that side of the colon. 2 randomized trials show it doesn't matter whether you do it in retroflexion or in the forward view, but after you get back to the hepatic flexure, go back down in the cecum, look at the cecum again in the forward view. A lot of stuff is missed in the cecum, and then if you want to go into retroflexion, do that. You can start that video also. So here is the left colon examination. In the left colon, again, I think an aggressive exam with a lot of movement, a lot of in and out, trying to get sort of a double examination. And the left colon, in the left lateral decubitus position, there's the additional issue of distension. And distension clearly correlates with detection. So I think CO2 helps because you're not worried about post-procedural abdominal pain. When you use CO2, you can pump as much gas as you want. If you want, you can rotate out of the left lateral decubitus position if the patient's awake, or you can fill the left colon with water and get a nice exam. Something that we do a lot is the tech will take hold of the patient's buttocks and squeeze it together. Because most of the time, when you can't see well in the left colon, it's because gas is leaking out the anus. We call that cricoid pressure. And I recommend to you cricoid pressure. It's very effective in achieving distension, and it's essential. Can I get the next slide, please? Okay, so often people are wondering, should we then employ some kind of extra technology? So 2 issues that technology can help us with. One is seeing more of the colon. So I think right now the dominant devices are endocuff vision. Meta-analyses suggest about a 7% gain in ADR. And then the GI device, which is the balloon on the end of the scope. This is FDA approved now, and in a study presented at the ACG meeting, it beat endocuff vision in a head-to-head study. Now, I think we're going to have to see more comparisons. It always takes a lot of studies to really establish what the truth is about detection devices. Let's go ahead and start that video if you would. This is the endocuff vision. I was using it earlier in the videos that were shown. We've shown in randomized trials that you can do withdrawal about 2 minutes faster with the endocuff vision on. You can actually insert about 30 seconds faster too, because the scope tends to not slip back as you're pulling loops out of the scope. You don't lose ground when the endocuff vision is on. There's another device called Amplify that we showed in a non-inferiority study, operates virtually the same as endocuff vision. A lot of people are concerned about the price of the device, but there may be some cost advantages from efficiency as well as increased detection. Next slide, please. Let's go back one. So maybe I can do that. So for highlighting lesions, there's several modalities, and I just want to say a word about electronic chromoendoscopy. You can start that video. So electronic chromo has kind of made a scientific comeback. I don't think that many people are really using it, but the newer Olympus version, the NBI, with the 190 scopes, has very good illumination and does improve detection. I'll show you that data in a minute, but I think that the color contrast between both adenomas and non-adenomas is greater in NBI than it is in white light. But you have to have a very high quality prep for it to be comfortable. I think you probably can examine the colon faster also in NBI, and I do it sometimes, not routinely, but especially when the bowel prep is just perfect. I think you reach a point of satisfaction that you've cleared the colon faster in NBI. And Fuji scopes are very good now, and their BLI and their LCI, linked color imaging, have also been shown to be effective. This is James East, individual patient data meta-analysis from gastroenterology showing about a 6% gain with NBI, and especially when the prep is high quality, there's a significant gain. I want to point out that ultimately what you want to know is whether these devices work for you. So I mentioned, of course, that colonoscopy itself is operator dependent. I think the benefits of the devices are also operator dependent. And I'll show you this study. We started several years ago reporting all of our detection studies with the results by the individual endoscopists in the study. So this is a study with endo rings, a device that conceptually is like endo cuff. And you can see on the bottom there that detection was improved. But if you look at the results of the individual endoscopist, you can see it's largely the result of one endoscopist who had dramatic improvement in detection. So I think when you look at these, ultimately what you want to do is get a feel for them yourself and preferably get some objective measurement about whether it's improving detection. If you could start that video. So AI. So AI is now available, and this is these programs all pretty much look the same. They put a box around the lesion for you. This particular program also is a differentiation program. So we're all learning how this is going to be sold. I think the data on it is pretty solid generally. And we're all asking, is it affordable? This is the GI Genius in action. This is Medtronic's device. And again, I don't have any association with them, but I have used this quite a bit now. It works the same way. It's a detection device only. And I have come to find, I think it's a useful adjunct to detection. There are certain kinds of lesions that it picks up very well. I don't think it does well with all categories of disease in the colorectum, but it's only going to improve as the programs. This is a patient with serrated polyposis. It's only going to improve. It's really lit up. Christmas season kind of light up there. So here are some of the randomized controlled trials. The average gain in ADR in these 5 trials, 11%. And that's the single biggest jump in ADR that we've seen with any detection device. I just read this study this morning. This is a randomized trial from China comparing standard colonoscopy to a CAD-E program to a CAQ, which is a program that is designed to actually assess the quality of inspection during withdrawal. We've heard a lot about this and seen trials now. So this is the first 4-arm trial comparing the 2 different types of AI plus a combination of the 2. And you can see that the combination was best, and it was better than CAD-E, although not statistically better than CAQ. So I think ultimately, really to get a reduction in operator dependence, we're probably going to need both CAD-E and some device that actually assesses quality. So in conclusion, you want to be aware of these minimum acceptable and aspirational ADR targets. Consider measuring SSL detection in your institution. Incredibly important to be familiar with the full range of appearance of precancerous lesions. Do all of the basics well. If somebody has a suboptimal ADR and a withdrawal time that is short, that's a marker that they're not using good withdrawal technique, and you want to focus in the teaching and remedial work on their technique, and the withdrawal time will follow. Right now, I think ECV and GI are the dominant mucosal exposure devices. AI seems to be the future of highlighting. I think its uptake is going to be dependent on how it's marketed and sold to us. And thank you.
Thanks so much, Doug. Really appreciate it. I'm sorry for my omission. I should have introduced my co-moderator for this session, Dr. Ji Young Bang, as one of our partners in the therapeutic or advanced endoscopy section. She's distinguished by the fact that she is the only one that really does the full spectrum of therapy, including third space, endoscopy, et cetera. And she also is our director of clinical research. So welcome to the podium, G. So next, I'm not going to introduce David. I'm just going to ask him to talk to us about cold snare polypectomy. I know this is an area that is a passion for you. So go to it, David.
Well, following Doug Rex, I feel like the guy that cleans up the podium after the Pope gave the religious ceremony for Christmas. It's always, we learn so much, Doug, and you are the king. I, again, wanted to make comment to the folks at Orlando Health that you are setting a new standard for quality and defining quality for Central Florida, but I think in this part of the country, if not the country in general. So congratulations, and the sky's the limit. What about, are there limits on cold snare polypectomy? Well, I took a little license to tease this out a bit as we come to Florida, but are we trending away from global warming? And in particular, is the new cold? Hot is now the gone, and cold is the new hot. Really no conflicts to declare on this one, but I still am available. The cold snare polypectomy, though, I wanted to give just a brief rationale. Why do we think that this is appropriate? Really to set the standard that it should replace biopsies, and that cold biopsies really are de facto and should go away with rare exception. Talk a little bit about snare dynamics, the size of the polyp, when should we start maybe thinking about something else, and when it's really not appropriate. So as we start to look at deliverables, we really have to talk about when we're treading on areas that we should not go. I'm going to make a brief comment about, since we're talking about larger polyps, some of the problems that you see in this case. Particular bleeding, I will tell you, is a universal issue for cold snare polypectomy. You will see it. If you didn't, you probably didn't do it as much tissue as you should. But snare sticking is really a problem, and we'll talk a little bit about some safety issues as how do you get out of that, and then finalize with safety as far as what's the data on cold snare polypectomy, and then really what do the guidelines say? What are the standards that we start to look at as we apply polypectomy to the present day? And then I'm going to leave with a little bit of legacy, where we start with who defined cold snare polypectomy, and then just leave you with a little bit of background on that. Cold snare polypectomy really is the emerging standard, really, for modification of how we treat most colorectal polyps. 90% of them are small. It makes sense that we can take them out with a snare. We don't need to show cautery a benefit here. The main advantage, obviously, is the safety. It's driven a rapid adoption into clinical practice. Obviously, the safety is driven by the emission of electrocautery, which avoids thermal risk not only to the vascular but to the mural structures. And significantly, what I think people don't realize, it's actually quicker. You don't have to hook up a grounding plate and connect the electrical surgical unit. And in fact, it may be more cost effective in that regard. And there are obvious reductions as it relates to the consequences of thermal therapy as it relates to post-polypectomy syndrome, perforation, and in particular delayed bleeding. Well, is cold snare polypectomy eliminate the perforation risk? There is data on this, and basically 2 meta-analyses that have been published, nearly 7,800 patients, no perforations. I found one study that looked at 1,200 plus patients. They had one perforation. It turned out it was a Schwann cell tumor. Again, incredibly safe. There are 2,019 cases that I found where the snare was used, but it was not a cold snare. It was a snare that was intended to be cold snare, but it was then transferred into a cautery type of dynamic, and again, potential cautery dynamic. And in fact, the initial snare did not cut through. And what the caveat is that the danger is that people will pull on that snare. It's not designed to be a cold snare. They're just not as efficient, and the thoroughness of the cut with these larger snares they're not just going to deliver the same as you would get with a dedicated cold snare. Cold biopsy, this is really should be gone. Cold biopsies basically have been outmoded. There's no benefit over cold snare polypectomy. They carry an increased risk, in particular, of incomplete excision, and in particular, they may be acceptable for a 1 to 3 millimeter polyp, especially if you use a jumbo forceps. I find sometimes, in particular in a 10 o'clock position, it's just not easy. You've got some loops in the scope. You can quick grab that in a small polyp. Maybe that's a reasonable thing to do, but again, it should be the exception. It should be never used for polyps greater than 3 millimeters. I hope that President Biden's colonoscopist knew this, because he just had a 3 millimeter polyp removed, and he had a tubular adenoma, I'm told. That great save. Increased rates of incomplete excision have been evident certainly with this type of approach. As it relates to considerations, really the upper limit size is just not known. It's not possible to remove en bloc large volumes of tissue, so we have to temporize that and recognize we're going to have to do it with repetitive piecemeal resections, and this requires time and patience. It's likely influenced to some degree by the snare type and the tissue characteristics, and I think that the thin wire is clearly a benefit. This is a RCT that was actually just published this morning, and looking at the RCT of a thick versus a thin wire. This is Michael Bjork in an international study looking at over nearly 1,400 patients. The thin wire, although it was 0.3, it was really not a thin wire. It's not characteristic of what we would call a cold snare by some of the newer criteria. And a thick wire obviously is totally different. That's really not a cold snare. There are no differences, however, in incomplete resection rates. The cold snare, the dedicated cold snare, there are some variances and improvements. Some are these sheaths are stiffer. Some have a metal tip, braided really to keep some of the fly away from the cold snare, where you don't have the tissue adherence that you'd get with cautery. The variable shapes from oval to hexagonal. And the wire characteristics, I think, are important. There are newer ones in particular that range down to 0.18 millimeters, and again, a very difference in different sizes. I like a new one that is also made of nitinol. I find if you're having repetitive use of some of these cold snares, they can get bent as you start to push on it hard and you're doing repetitive piecemeal resections. The nitinol seems to have much more resiliency and recaptures the same type of approach that you would have with the de novo snare. The targeting of this is obviously to make sure you get an adequate resection margin. 2 to 3 millimeters is typically the target. There's no extended thermal effect, and obviously the delayed bleeding risk is basically zero. Other considerations is, in particular, when to look at this. If you have patients that are going to remain or resume anticoagulants or antiplatelet agents, I think this becomes really a nice ace in the hole type of technique. Certainly if there are comorbidities that they don't tolerate, in particular electrocautery complications, if you get into some of those, and the patients are going to be a high risk. And certainly if there are patients that come a long way and they then go back again to a center that doesn't have the availability of an advanced endoscopist, and that patient has a delayed bleeding, you're really up the creek. They have to come way back. So again, remote locations may be a real go-to in particular on this. One of the areas that I really have looked at, and we published this a couple years ago with Dave Lieberman, Lauterbaum, looking at a database of over 500,000 patients, delayed complications. We always think about perforation and bleeding, but delayed complications as it relates to colonoscopy include like strokes and myocardial infarctions and a variety of things that we never see. And we looked at this in a national registry and found the associated odds ratio was increased by nearly 10 times, over 10 times, in the associated use of antithrombotic medications. And again, Yuri Lauterbaum has just published this. It's coming out next year, but non-GI events, and looking now at a larger database, 4.5 million in California, and they found that GI events over the age of 65 were less than the non-GI events. So the older patient actually had the non-GI events. The risk period here ranged from 1 to 125 days. Moving into what's the size, well, there is RCT data as it relates to 6 to 9 millimeters. This is looking at 500 plus patients, and it was non-inferior for hot versus cold snare polypectomy. The post-op bleeding risk, however, is only evident with the hot snare polypectomy. Another RCT looking at same type of variable size, up to 8 millimeters. Not only procedure time was less, there was no bleeding really in either group in this circumstance, and abdominal symptoms were a lot less as it relates to the patients that had cold snare polypectomy. The overall drive on this is that piecemeal resection seems to be an important risk factor for residual polyps. And in particular, then, that makes it easy to say, well, maybe we should do a lift resection on this and put some elevation to this polyp. And is there really evidence on this? And I'll speak to that again, but the RCT data on this, not yet, that it seems to make a difference, and it may actually not be needed at all. Systematic review on this. This comes from Michael Bjork's evaluation of a retrospective looking at their data from about 6 years in Australia. Primary outcome was residual polyp after they had a follow-up colonoscopy, and the secondary outcomes looking at technical success for complete resection and adverse events. They had 14 studies, 911 patients. Only 17% in this evaluation got cold snare or cold EMR. There's no difference as it relates to residual polyps in this. It was very low, 4.3%. The polyp size was, again, driven more for larger polyps, tended to get more hot polypectomy. But again, the residual polyp rate also increased with size. We know that makes good sense. But again, data that this larger polyps certainly make it very approachable for even cold snare polypectomy. And delayed bleeding risk was virtually zero. Again, cold snare virtually takes away delayed bleeding. What about with the submucosal resection? This is, again, a study that looked at, in principle, again, trying to get an in-block resection. And this is, again, a study from Michael Bjork that is in press coming out early next year. They looked at a median diameter of 14 millimeters in these polyps, but ranged up to 4 centimeters. Cold snare polypectomy was used to resect 22% of these. And again, without resection, they were able to get basically total resection without a submucosal lift. Adverse events, really immediate bleeding was evident, 3%. Delayed bleeding, again, resonant number 0. Really makes sense when you talk about cold snare. And again, this was very important because about 12% of these were on antithrombotic drugs. So when we start talking about antithrombotics, I think we way over interfere with the use of antithrombotics. Just a caveat, do not ever make the mistake or let your staff tell your patients, stop your antithrombotics because you're getting your colonoscopy. You have medical legal responsibility, and I think you can be held liable if they have a complication if you make that order as opposed to the prescriber. So again, be very cognizant of these agents, and I think we can do a lot better and maybe do a lot of these patients still on antithrombotics. How about 2 centimeters and beyond? We're raising the size here. Traditionally, the upper size is really limited by trying to, if we were going to go for a conventional endoscopic mucosal resection of 20 millimeters. But again, cold EMR seems to simplify this, and snare resection can certainly be consistently applied repeatedly with piecemeal resection. And again, targeting smaller and multiple pieces. This is something that really says, well, we don't really have any size limit on hot EMR. What about cold EMR? So why do we apply an arbitrary size barrier when we now have conventional EMR where there is no real size barrier? What about as it relates to cold snare resection of sessile serrated lesions? Again, the primary indication for cold snare was sessile serrated. But again, contrast to large adenomas, these are so much more approachable to cold snare. They're thin mucosa, they're slightly thickened over the normal surrounding. The submucosa is loose, you don't have the fibrosis in the submucosal area. And this is a study also that comes from Michael Bjork looking at a multi-center analysis of 562 patients. Mean size here was 2.5 centimeters. There was no difference in technical success, and the differences, again, relative to the post-endoscopic resection, bleeding, 0, cold snare, and deep mural injury, 0, cold snare. So again, even for large lesions, cold seems to be incredibly safe. Cold snare for large sessile adenomas. This is maybe a little different. Residual neoplasia for conventional endoscopic mucosal resection is higher, 15 to 20% in some studies, higher than sessile serrated lesions. I think that's because we capture the sessile serrated lesions better. And the adenoma prediction recurrence is higher in the odds ratio, the hazard ratios are increased nearly twice for adenomas. Selected conventional adenomas without submucosal invasion is really the key as we're trying to look at for cold snare. Those are not going to be something that we're going to use cold snare, but lateral size is not a selection factor for cold EMR. And in particular, if you look at this in regard to, we're frozen here. Look at this in regard to these large laterally spreading adenomas, sessile serrated adenomas. These are best restricted to lateral spreading Paris 0 to 2A, or what we would call nice 2-pit patterns. So again, prediction of non-submucosal invasion when you start to look at your selection. So who are the ones that you don't want to go after with cold snare polypectomy? Well, if you're trying to get a patient with a submucosal invasion and you're going to resect it, you've got to resect that in block. If you're going to tackle that, you've got to get the whole tissue so the pathologist can really give you really what the dynamics of the invasion is. So the lesion morphology would be something that would be also somewhat a wave off, the non-granular depressed lesions, and the mucosal pattern certainly will derive when you're going to wave off on this. And this is looking at a variety of suggestions here that you would say right off the box. You've got depressed areas here, you've lost the vascular pattern and you see some superficial ulceration. Again, depressed, failure to lift in this particular circumstance. And then you look at the nice pattern here, it's a nice 3. This is certainly, you see this brownish discoloration relative to the background. You see the disrupted or missing vessels. And the amorphous pattern, any of these three actually define a 94% accuracy and 96% negative predictive value for submucosal invasion. So these are things that you're not going to tackle. What about you're taking these larger lesions and the snare gets stuck? What do? Well, a couple tricks and suggestions. One is larger volumes of tissue obviously are going to potentially create more resistance. We call it a cold snare stall. It's not a really favorable circumstance, but if the snare fails to resect with full closure, don't switch to electrocautery. Again, you shouldn't be using that snare anyway. I think you should use a dedicated cold snare, but pause. Give it a little bit of time. Maximize the force transmission. Try and get your axis in the most reliable way that the force of closure is going to be in its best advantage. Maintain insufflation in the snare closure. Be patient. Try and reduce any loops in the angulation of the tip. And again, straighten the catheter, including outside the scope, because again, that changes the dynamic of how your closure is potentially occurring. And then move it back and forth gently. Again, do not avulse the tissue. Don't tear it and pull back, and give it time and wait for it, and transection may occur. And if it doesn't, a few seconds, then what do you do next? Well, first, release the entrapped mucosa, submucosa. So reopen the snare a bit, go about a third of the snare handle, lift it up or tenon a little bit. What you're trying to get is that submucosal and the muscularis perhaps to drop down and release the stalk of the submucosa. And then lower the lesion again, let's loosen the snare again fully, and then reapply. It's very analogous to what we would do if we were repositioning on a pedunculated polyp and trying to reposition it on a stalk. So again, be patient, take time, do not avulse these tissues away, and that's where I think you'll stay safe. Management of bleeding, expect it. Acute, it's common. You'll see it virtually all the time. It's incredibly brief. And delayed bleeding, virtually never. So what happens? Well, if you are having an ongoing ooze or a more vigorous bleed, it's more likely if you have defined bleeding risk. So the patient's coagulopathic or they're on antiplatelet agents. What do? Well, flush. The water infusion into the submucosa will tamponade the bleeding and virtually always stop it. You can tamponade it with the scope and push on that. You can rarely inject it or grab it with a snare. Again, give it a little bit of time. Delayed bleeding, virtually never. Do expect that you'll see tissue protrusions when you see these little white spots and yellow spots. We see this anywhere from 10 to 15% of the time on cold snare polypectomy. This is something that you would expect. It's not worrisome. You don't need to do any more. Histopathologically, these are submucosal and muscularis. There is absolutely no residual adenomatous tissue in this. Do not worry about these. You don't need to do anything beyond that. More you see it with larger resections, in particular the polyps when they're greater than 6 millimeters. It's not associated, however, with any type of pathology, so do not worry about this. Expect it, in particular for larger polyps. What do the guidelines say? In the most recent iteration of the guidelines, the new norm is for diminutive polyps, 5 millimeters, and even for small, 6 to 9 millimeters. High complete resection rates are very safe and effective. Strong recommendation, high quality evidence, cold snare polypectomy. What about for the cold snare polyp or cold polyps, cold forceps? This is absolutely not the standard of care. Against this, high rates of incomplete resection, less than 3 millimeters. Certainly, if it's technically difficult, use jumbo forceps. Again, strong recommendation, a little less on the quality evidence, but again, the old de facto no longer should be the standard for using cold forceps. And against hot forceps, we virtually never use this, maybe the exception of hot avulsion, where you're doing in polyps, but for, again, hot biopsy for polyp resection, incomplete resection, inadequate pathology, strong recommendation, moderate quality evidence. So cold resection is the rule, hot resection is the exception. So in conclusion, what I'd leave you with is the cold resection is remarkably safe. If you're not using this, you should. It's comparable to and low complications, not only for small but large polyps. This includes anticoagulants, antiplatelet agents, and coagulation risks, patients that are cirrhotic or thrombocytopenic. Again, be very cognizant about not necessarily trying to have to stop antiplatelet agents and use the appropriate technique. And I think really it's important to use a dedicated cold snare and not to change to a cautery snare and apply cautery. These are not made to cut like these cold snares. Avoid the cold biopsy approach we talked about. Piecemeal technique, once you get into the larger polyps, includes a mucosal resection edge that's 2 to 3 millimeters. It's not suited. In particular, you wave off for large sessile lesions if you suspect submucosal cancer, and certainly not for pedunculated polyps. The vascularity of these things would be hard to not cauterize, in particular for bleeding risk. And the efficacy, regardless of the polyp size, I think is really evident for sessile serrated lesions in particular, and I think the evidence on adenomatous polyps is evolving. It's probably yet to see a little bit more evidence on this for large trials. Doug has got one that he'll tell us about, hopefully in the breakout discussion, talking about adenomatous polyps in colon resection, but I think it's really important to recognize. Doug Rex, as you recognize, is the pope of the colonoscopy, and I think Doug's first comment a couple years ago, he talked about the cold snare was the cold snare revolution. And I think you termed the concept that really got everybody going. So I just gave Doug the credit for the development of cold snare resection, and the whole development of cold resection was really somewhat relative to Doug's expertise. Well, I went back, Doug, and I'm sorry, dude, but I tracked it back to 2004, July 13th, and in fact, what I saw was it was actually Buffett, who came out with his License to Chill album in July 2004. And so you may be second, and you're an awesome second, but nonetheless, Buffett gets credit. And snare and polyps or margaritas, I'd say at present day, best called. Thank you for listening.
Thanks, Dave. So this group will be finished by Darrell Pardi. He's a professor of medicine. He's also vice chair of the Division of Gastroenterology and Hepatology at the Mayo Clinic in Rochester. And he's going to talk to us about fecal transplant.
Okay, last, hopefully not least, and this is an exciting topic because it's very much in evolution as we speak. So, here's my disclosures. We'll talk about off-label use. So the present is FMT for recurrent C. difficile infection. The future is non-FMT microbiome replacement therapies and using FMT for other conditions. And I want to thank Dr. Johnson for setting up this talk with his introduction earlier about the microbiome. All right, so you understand the rationale. So if we go from the upper left here, the normal flora has a diverse population, abundant, meaning the number of organisms. And when exposed to risk factors for C. diff, most typically antibiotics, but it can be other things, you get a lower abundance and a lower diversity, and that opens up a niche for things like C. diff spores. So if the patient dysbiosis is exposed to spores, they get colonized. If those spores germinate and produce toxin, you get disease. When we treat with antibiotics, we kill the live form of C. diff, but we don't kill the spores. So you go back to that dysbiotic state with C. diff colonization. And then if the spores germinate before the normal flora is restored, you get reinfection. And you can see from the box the rate of, or the risk of reinfection goes up each time you've had an infection, because each time we treat C. diff with antibiotics, we hurt the normal flora. And then when we do microbiome restoration, whether with fecal transplant or other things I'll talk about, we restore that colonization resistance, and even if the spores are there and they germinate, there's no place for them to cause a repeat infection. Okay, so that's the rationale, but does it work? And you know it does, or they wouldn't have invited me to speak. So here's an older meta-analysis, but it makes the point, multiple studies looking at this. On the left, single infusions, 84% effective. On the right, multiple infusions, you pick up another 8% or so efficacy. So no doubt it works on open label experience, and we now have several randomized controlled trials. So this is the first one, comparing one or more fecal transplants on the left to vancomycin on the right, with or without bowel lavage. So some naysayers thought it really isn't the bacteria, it's the fact that we're giving them the FMT through colonoscopy, and we're rinsing out all the spores. So it's really the bowel prep that's the benefit, and this study showed that that's not true. Here's a randomized placebo-controlled trial where autologous stool was used as the placebo. And you may have seen this published in Annals now several years ago, but overall about a 38% or 28% efficacy compared to placebo. But when you looked at the two studies, the Brown study was almost a 50% improvement in recurrence rate with fecal transplant, whereas the New York site was no benefit. Not because the fecal transplant wasn't good, but because placebo was incredibly good. And some sort of post-mortem on this study, many of those patients in New York knew the study was coming, So the investigator kept them on vancomycin for up to a year or sometimes more. So it raises the question, maybe a really prolonged course of vancomycin can prevent C. diff recurrence. That's a hypothesis generating. They didn't investigate that in this study. All right, and then now this more recent study, FMT in the dark blue, better than fidaxomicin in the light blue, and vancomycin in the gray. So it's a really good treatment for preventing recurrent C. diff, but it's not perfect. So can we predict recurrence after fecal transplant? Well, probably the most important one is the top bullet, and that's using antibiotics within the first 8 to 12 weeks after the transplant. So I tell my patients, tell your doctors you've had a hell of a time with C. diff. Do they really, really need to use antibiotics for your sniffles, or can we get by with some decongestant? And I'll talk about vancomycin prophylaxis at the end. If you do fecal transplant for severe complicated or inpatients, there's a higher rate of failure. And sometimes we'll do serial FMTs on these patients, do 2 or 3 to try to give them the maximum benefit. And then your IBD patients, as you know, have a higher risk of C. diff overall and a higher risk of failing or recurring after fecal transplant. Okay, so it's effective, but is it safe? Safety of FMT is obviously dependent on procurement of stool from well-screened and well-characterized donors. This is what we do at Mayo, and all the companies working on products derived from donor stool do the same thing. Frequent health and exposure questions to your donors. We do it every 3 months. If they pass all those questions, we then test stool and blood for multiple infections. And now in the COVID era, we do nasopharyngeal screening for COVID every 2 weeks. And we quarantine the stool and don't use it until they've had 2 serial COVID tests being negative. And with that, we've done over 1,100 transplants. We've not had any serious infections. There have been reports, though, of new medical conditions, many of them autoimmune in nature, raising the possibility that maybe this microbiome that doesn't belong there can transmit disease. For the vast majority of these, there are single case reports or maybe 2 case reports, so the possibility of a chance occurrence can't be excluded. Importantly, and the FDA requires that we tell patients this when we get consent, we do not know the long-term effects of fecal transplant. I think there aren't any, but there's a large NIH-funded multi-center study looking at long-term effects. And you've probably heard of these recent cases of infections transmitted by FMT. So 2 cases of extended spectrum beta-lactamase sepsis, one of which was fatal, and a handful of cases of enteropathogenic E. coli and Shiga toxin-producing E. coli. So despite very careful screening, things can still get through. A question we get all the time is, can you do fecal transplant in your patients who are immunocompromised, like your IBD patients? The top is a study we did from Mayo, 23 patients with hematologic or solid cancers on cytotoxic chemotherapy. No serious adverse events or infections attributed to fecal transplant. And then an earlier multi-center study of 80 patients immunocompromised for a variety of reasons. No definite adverse events related to the fecal transplant. There was 1 aspiration during colonoscopy, and 5 of their IBD patients flared after FMT, but no serious infections after FMT in this immunocompromised patient. So we do it in immunocompromised patients with the exception of absolute neutropenia. All right, so that's the present. What about the future? I think the incredible efficacy of fecal transplant for patients with multiply recurrent C. diff begs the question, why wait for them to have 2, 3, 4 infections? Why not do it after their first recurrence or even after their first infection and prevent recurrence in the first place? And there's trials ongoing to look at that. Really important for those of you who consult in the ICU, we and others have reported experience with fulminant C. difficile infection, so sepsis on pressors. Surgeons say they're too sick to go to the operating room, patient's going to die. We've done fecal transplants on 6, and 5 of them responded. And there's other people that have reported larger experiences showing really almost hard to believe efficacy, to the point now where I tell my residents in the ICU, before you call the surgeon or at the same time you call the surgeon, call us, and we'll think about a fecal transplant before they go to surgery. I think the true future is this concept of tailored probiotics. So do a microbiogram on the patient and see what's missing or what's there and too much, and then design a microbiome replacement therapy based on their individual profile. That's a little bit pie in the sky currently, but I hope we'll see that in the next couple of years. So here, just a quick one study looking at FMT for primary C. diff, so no recurrence after the first infection. The middle boxes are patients treated with metronidazole, and the right are patients treated with FMT, and that rust color box is the failures. And you can see in this small proof of concept study that fecal transplant had many fewer failures than antibiotics in terms of recurrence. And there's controlled trials going on looking at that. Here, just a little bit of data supporting what I just said about fulminant C. diff. Numerous case reports suggesting efficacy. A big systematic review meta-analysis of 16 studies and almost 700 patients. So these are really, really, really sick patients. And they had a 61% cure of C. diff and only an 11% major adverse event rate. So these are patients that don't really have many options and likely going to die if we don't do something. So I think very encouraging. And the bottom study was not included in that meta-analysis, suggested maybe it's a little less effective. And the important thing here is that of this, the bottom study, most of the patients responded to the fecal transplant, but then had a recurrence. And that's why for these patients, we'll typically do 2 or 3, depends how long they're in the ICU and how sick they are. We'll do serial FMTs to try to prevent it from coming back. Okay, so what about non-FMT microbiome replacement therapies? So this is where I think the future is. And there's several products being studied for this. The 2 I underlined are closest to market, and those are the 2 I'll talk about. So the first is SER-109. This is a consortium of spore-forming firmicutes, and they process the stool in a way that causes sporulation in those bacteria, kills everything else. They collect the spores, put them in pills, pills given over 3 days. The recurrence rate with SER-109 in patients with multiply recurrent C. diff, where you would expect recurrence rates to be 60, 70%, was 11%. Very similar to what we see in fecal transplant, and well better than placebo, which was 41% recurrence. And I expect approval of this drug next year. The second is an enema called RBX2660. Similar thing, patients with 2 or more episodes of C. diff, placebo versus microbiota suspension enemas. And you can see in the graph, 58% success with placebo compared to 70% with the active enema. So maybe not quite the separation we saw for SER-109, but still statistically significant. And because they have more safety data for this product, it's probably going to be the first one approved, but both of them should be available next year. So it's highly likely we'll have these available. The cost is to be determined. And the big question is, what will the FDA do with FMT? Is this the end of FMT? I don't know. We'll see. I think they will still allow us to do FMT, but they'll make us have an IND if we want to do FMT. Remember a couple of years ago, they were going to make us do that. And then there was an uproar, and they used what's called enforcement discretion. The rule's there, but they don't enforce it. I think once they have an approved product, they'll require that we do FMT under an IND. All right, I'm going to just quickly go. Dr. Johnson alluded to this very nicely in his talk. As the number of conditions that are associated with alterations in the gut microbiome grow, the opportunities to study these microbiome replacement products in those conditions also grow. And that's one of the things I'm most excited about with these products, especially the pill. You know, you can't do FMT every day or every week. I guess you could, but it wouldn't be very practical. But when you've got a pill that's as effective as FMT, now it becomes easier to study, say, serial microbiome replacement in IBD or IBS or obesity or whatever. And again, I don't have time to go through all of these, maybe next year, Rob, but I did think we would talk about IBD, and Dr. Johnson set this up nicely. Lots of evidence that microbiome alterations are at least associated with IBD and outcomes in IBD. Animal models for IBD require that there be microbes present in the colon. Fecal diversion can treat IBD, on and on. So lots of evidence that the microbiome may play a role. And several small randomized controlled trials of fecal transplant in ulcerative colitis, 3 of the 4 suggesting benefit, and the meta-analysis also showing benefit. So a lot of excitement in the field that maybe these sort of natural products or these probiotic-like products could treat mild or early ulcerative colitis. And with great anticipation, the company that makes SEER 109 made another product called SEER 287 for ulcerative colitis. Same concept, it's a consortium of spore-forming firmicutes. Phase 1 study was really very exciting, 40% remission with this product versus 0%. And with great anticipation, they launched a phase 2 study and just announced in the last month or 6 weeks that it was completely negative. So is that the end of FMT or microbiome replacement for IBD? I don't think so, but I think it's going to cause us to step back and scratch our heads a little bit. Could there have been better patient selection? Could we have stratified patients, perhaps based on what their own microbiome looked like? And again, this idea that maybe in the future we will do a stool sample on our patients with IBD, run it through some kind of a machine and tell us what's wrong with their microbiome, what are the bacteria expressing, so-called metabolomics, maybe incorporating genomics, and then do a designer drug for that patient. The other thing that several companies are working on is taking bugs, taking bacteria, inserting genes for certain products, like anti-inflammatory cytokines, for example, then using those drugs as using those bugs as a probiotic to deliver the drug to the colon. Very exciting. So take-home points, the present state, FMT is highly effective for recurrent C. difficile infection and reasonably safe. The near future is these microbiome replacement therapies are being investigated and likely we'll have 2 of them approved in the coming year. And perhaps further down in the future is FMT or microbiome replacement for several other conditions, and the list grows by the day. So thank you.
Wow, fantastic talks from everybody. Thank you so much. So Dr. Bang now will do some case presentations, and again, the invitation for you during the case presentations. If you have a question, just come on up to the microphone and I'll acknowledge you as soon as there's a sort of a break in action. So take it away, Dr. Bang.
Thank you. Good afternoon, everyone. This session, this kind of cases are on C. diff and some colon polyps. So this first case is a 76-year-old female who was admitted with diarrhea, fever, and abdominal pain. She'd been having loose stools 8 to 10 times a day for the last 2 days, and she was actually treated for UTI with Augmentin about a month ago. Her most significant past medical history includes breast cancer, which is in remission, and then she also had hypertension, diabetes, and reflux. She's had a mastectomy before, non-smoker, no alcohol, and medications included aspirin, antihypertensive, insulin, and a PPI. So physical examination, just notable for a dehydrated, fatigued lady. She was SIRS positive with tachycardia, leukocytosis, white cell count of 14. Otherwise, she was afebrile, blood pressure was okay, not tachypneic. And she had no signs of peritonitis, but she was tender in the left lower quadrant. Not surprisingly, her C. diff test was positive. We did an enzyme immunoassay for the toxins. So my first question is, given that she has C. diff infection, are there any other diagnostic testing required, such as CT abdomen or colonoscopy? We'll start with Dr. Pardi.
Okay. I'll agree with Dr. Johnson, who's shaking his head no. I mean, in fact, so if we're going to do a colonoscopy as part of the evaluation of diarrhea and we find C. diff, we cancel the colonoscopy. And with a normal abdominal exam, you're not worried about megacolon or perforation. A CT scan would be of no help.
Okay, so if you're not doing no CT and no colonoscopy, we would go straight for treatment. So what would be everyone's first-line treatment of choice? So the choices are oral vancomycin, fidaxomicin, or metronidazole, and then would we just go straight to fecal transplant as first-line therapy?
I'd love to see a show of hands. How many people say vancomycin? How many people say fidaxomicin? And how many people say metronidazole?
Oh,
Okay, good. So the new guidelines have settled in. So it used to be metronidazole for non-complicated or non-severe C. diff. That's out of the guidelines now unless the patient can't afford fidaxomicin or vancomycin. The ID guidelines that were updated earlier this year actually pick fidaxomicin as first line because it's better at reducing recurrence than vancomycin. They ignored cost, and we can't ignore cost. So again, in my practice, I typically use vancomycin unless the person has 2 or more risk factors for recurrence, then I'll consider fidaxomicin.
So make a comment about vancomycin, because I think that the dosing on it is often in great error. Over 125 milligrams 4 times a day is virtually never needed. So in people that really are severe, you can say that those patients when they're toxic colitis, those are patients where the higher doses would be important, but not in any other circumstance. The second is on vancomycin is that it's inordinately expensive if you just write it that way. We have a compounding pharmacy, so we get an IV formulation and just have them encapsulate it. It's $1 a capsule, so you can use a compounding pharmacy and really save your patients a lot of money.
I'll agree to that. A lot of times we see patients with recurrent C. diff being treated with higher and higher doses of vancomycin. There's no evidence for that whatsoever. The 125 QID exceeds the MIC for C. diff by like 100-fold. So you're really wasting vancomycin, and it's not cheap. And then a final comment, is if you want to use fidaxomicin, it's very expensive, but they have a patient assistance program, and it's not too hard to fill out the form. They can get it for $50 a prescription.
Is there any additional benefit of using IV metronidazole along with oral vancomycin? I see it often in the hospitals.
Yeah.
Oral vanco plus IV.
So the question is, does IV Metro add anything to oral vancomycin? And it's in the guidelines for the severe or fulminant C. diff, hypotensive in the ICU, megacolon. I don't know how well studied it is, but it makes sense. These people are trying to die on us. So yeah, that's when you'd use high-dose vancomycin plus IV metronidazole.
IV metronidazole is excreted in the biliary tree, so it actually can get there in patients that have an ileus. That may be helpful. You can also use vancomycin enemas, which is the other way to deliver it if you, again, have patients that have severe ileus. But I think that vancomycin really needs to be reined in on the dose.
Okay, so this patient did end up getting a CT scan. Sorry.
Why not?
Sorry, that was very loud. It showed diffuse colonic wall thickening. The colon was a little dilated, but no evidence of colonic perforation. So she was managed with supportive care, vancomycin, 125 milligrams Q6 hours for 10 days, and she was discharged home 6 days later. But alas, unfortunately, she had 2 further recurrences of C. diff at 2 months and then 5 months post-initial diagnosis. So she had pretty much similar symptoms, diarrhea with abdominal pain and positive enzyme assay for C. diff toxins. So what would you recommend as the next treatment approach for recurrent C. diff infection?
Before you address that, can I make a comment? There are people that would order a C. diff test just to document that they adequately had treated the patient once they've been treated. Do not order a C. diff test in the absence of diarrhea. And diarrhea actually in C. diff may persist for a while because you've changed the microbiome and it may not reflect it at all. So if you have a question, then I would do a colonoscopy or a flex sig just to look at the activity. But in the absence of diarrhea, you never do a C. diff test. And it may actually linger positive in the absence of a pathogenic C. diff for up to a month.
Or longer.
Or longer,
Yeah, so test to cure is not recommended. I do like the fact that you tested her recurrence for reinfection because post-infection IBS is seen in about 25 to 40% of patients, depending upon the severity of the C. diff. We see it all the time in our C. diff clinic. And you repeat a test, and it's positive, you treat it like C. diff. If it's negative, then the negative predictive value of both the EIA and the PCR is very high. So a negative test really goes against it being recurrent C. diff, and then you treat for irritable bowel syndrome.
So 2 points. One, again, to reiterate, scope the patient if you really have a question, if it's active C. diff as opposed to this post-irritable bowel or persistent C. diff positive in the absence of pathogenic. I make a very strong point of potty hygiene. So when I do my fecal transplant patients and really even the de novo C. diff, I send everybody home with very explicit instructions. They've got to do a high-level disinfection of their bathroom. The spores of C. diff can be viable for up to a month or more. And what happens when you, if you start to look at what happens when you flush your toilet with the toilet seat up, this is really a bad thing right before dinner or cocktail time. But the idea is the plume actually can deposit in the hard surface areas in the bathroom. And in fact, if you look at toilet bowl microbiology, it actually mirrors your toothbrush if you leave your toothbrush out for 3 days on the counter. So you have to be very cognizant of these patients need to do a high-level disinfection. I've got no data to show it works. I can just tell you from preventive maintenance, when you have C. diff, I tell them do a high-level disinfection. It's a Clorox level. All the surface areas go down. I haven't changed their head on their toothbrush. It just makes intrinsic sense.
That's something I think we do a bad job at. As gastroenterologists, I'm guessing everyone who dismisses patients from the hospital, maybe other than infectious disease, that we don't talk enough about infection control. So not only for them getting recurrence, but for their family members. And there was a study that looked at patients discharged from the hospital for C. diff as compared to patients discharged from the same hospital for another indication. As you might imagine, the attack rate in their family members was like 100 times higher if the patient had C. diff. So in addition to what you said, I recommend that they use their own bathroom. Family members use a different bathroom if that's at all possible. Obviously wash their hands very well, both them and family, before they eat or drink. And then just to make the point that you don't need full strength bleach. Dilute bleach is enough, but toilet seat, under the toilet seat bowl, floor, anywhere they've had an accident. So anyway.
So are you going to answer the question?
Okay. I was just getting to that. All right, so this is a patient with 2 recurrences, 3rd infection, by definition, multiply recurrent C. diff. You didn't say what they were treated with. The new guidelines are, remember, the old guidelines were you treat the first infection with either metronidazole or Vanco. You treat the first recurrence with the same thing. Now the guidelines say if it didn't work the first time, do something different the second time. So if you use standard Vanco the first time, you use vancomycin taper the second time, or Fidexo, et cetera. If it keeps coming back, then I think the best option is standard vancomycin for 10 to 14 days and then fecal transplant.
So that's what she did have. The first recurrence we treated with a tapered course of vancomycin, and then she was considered for fecal transplant for the second recurrence. And so this is the final kind of discussion point. So I was wondering if everyone could just kind of put their 2 cents in. So what do you think is the optimal method for performing fecal transplant? Who or what is the ideal donor? Who should be performing fecal transplants? What is the follow-up required? Should probiotics be administered as routine for prevention of further CDI? And what should we do about her PPI? I know it's a lot of questions, so.
Well, I'll try to go through those quickly. We don't know the optimal method. There was a study comparing nasoduodenal tube versus colonoscopy versus enema versus some combination. They were all equally effective. The one that wasn't as effective was nasogastric administration, which not only is gross, but it's allowing the stomach acid to kill your bacteria. So it doesn't really matter too much. Ideal donor, C. diff, I think, is the low-hanging fruit. It doesn't matter if it's a known donor or a standard donor, if it's fresh or frozen or lyophilized or encapsulated or enemas, it all works. For things like IBD, obesity, autism, graft-versus-host disease, et cetera, I think it's going to be harder. And then the question about ideal donor becomes important. Who should be performing FMT? We do most of ours by colonoscopy, so anyone that can do colonoscopy, you're squirting in some cloudy liquid at the end, so anyone who does colonoscopy and can get to the cecum should be able to do it. We follow up a week later, just sort of standard, how are you doing, are you having any symptoms, but no other follow-up is required. One I thought I had in my slides, but I didn't, is for a patient that's had multiply recurrent C. diff, and they need antibiotics for something else within 3 to 6 months afterwards, sinus infection, UTI, whatever. We're now looking at oral vancomycin prophylaxis. So you give whatever for the sinusitis, and you give vancomycin 125 BID for the duration of that antibiotic plus 5 or 7 days after. And there's pretty good uncontrolled evidence that that decreases the risk of recurrent C. diff. Probiotics really have no role. I'll stop there. And PPIs, I think, are interesting. It's in the guidelines that they are associated with primary C. diff and recurrent C. diff, but the data is pretty weak. And if you look at studies that control for confounders, the association actually goes away. So what I do is if someone has terrible heartburn and the only thing that controls it is PPI, I ask them to stay on their PPI. If they can control their heartburn with an H2 blocker, then I'll switch. If they have no good reason to be on a PPI, like unfortunately too many of our patients, then I ask them to stop it.
Okay. Any further thoughts?
Can I just rein in on this, just a couple of these? The ideal donor, we started fecal transplant a long time ago, and I would take any family member that met all the infection stuff that we had there, but there's actually transmissible, at least in an animal model. You can take stool from a fat mouse and put it in a skinny mouse, in a germ-free mouse, and make that mouse fat. So there are transmissible diseases, at least we can see, at least on animal models, getting back to our microbiome, that, again, cognizant, it just becomes an issue if you're not using open biome and some of the applications. If you go back to making your own fecal transplant stuff, it's important. The second is the probiotics really, to Darrell's point, have been totally debunked now. I think there's an article that just came out again this week on probiotics, totally refuting the Saccharomyces data that Chris Horowitz had put the pilot study together and was included in the initial guidelines. As it relates to PPIs, I think that PPIs should be stopped in anybody that doesn't need them. We're overutilized medications, and the best, if they need it, they should take it. It never made sense to me why PPIs would cause more of an issue. C. diff is an acid-resistant spore. So it makes no difference when you have a condition like pernicious anemia. If I were going to do an evaluation, why don't pernicious anemia people all get C. diff? It doesn't make sense. So the idea of stopping this doesn't make sense if they need it. And the data, at least conjecturally, is that maybe the PPIs changed some of the bile salt pool, and some of the bile salt pools led to the activation of C. diff. Again, I say if they don't need it, they shouldn't take it. If they need it, they should take it.
I agree. And my comment about the ideal donors assumed they weren't obese and didn't have any condition that has been attributed to the microbiome. There really is not good evidence that FMT can transmit obesity in people, but we don't push our luck with that. And you probably are aware that Open Biome is no longer shipping product unless for emergency use. So if you're going to do FMT, either you have your own donor program and your own sort of stool bank, or you use what's called known donors. So they come in with a family member, and the family member is going to donate. So again, make sure they don't have any diseases. And then you have to test that donor for stool infections, HIV, syphilis, et cetera. And those are generally not covered by insurance. So they'll be paying for those tests out of pocket. And then the final thing, maybe the last time I talked to a patient about known donor, an older gentleman with recurrent C. diff, his son was with him. I said, you can have your son be a donor if you want. He said, "Doctor, I've taken enough crap from this guy already."
Okay, thank you. All right. On that note, we've got some colon polyps now because Dr. Rex is falling asleep. So, okay. We have time for just one polyp, so I guess we could just go with this kind of medium-sized polyp. So it's very simple. This is what the polyp looks like. It's in the hepatic flexure. It's 2 centimeters. Dr. Rex, what will be your optimal technique for removing this polyp? If you could just comment on the choice of snare you would use, whether you would do this piecemeal versus en bloc, and then choice of solution if you were choosing an EMR technique.
So for choice of solution, basically, usually a viscous solution. I think we don't have comparative studies between the ones that are commercially available. Elaview, I think, is a little bit too light. ORISE creates some histologic artifacts and can distort scars at follow-up. So what's the other stuff that GI Supply is making? It's a very nice dark solution. As long as it's viscous, I don't care. I would do this. I can't see the whole surface of it. You have to look over the entire surface of the lesion. It's an adenoma. I don't see any nice 3 features on it. I would characterize it probably as non-granular. It's a little bit bulky. I would probably remove it in most patients with electrocautery. But if you got it really well injected, you might be able to piecemeal it out. The bulkier they are, the more difficult they are to take out cold. And I probably would use 15 millimeter. I think over in the right colon especially, you should limit yourself to 15 to 20 millimeter snares. If you're using electrocautery, you're going to get, you increase the risk of muscle injury, I think, when you use really big snares. And again, you don't know how much of this is over the fold. It's 20 millimeters in diameter. I don't know how far it goes over that fold in the hepatic flexure. The hepatic flexure, the distal ascending colon is an area sometimes where going into retroflexion is very nice to see how big the lesion is, injecting it in retroflexion and pushing it back over. But I always say you never want to underestimate how much polyp can be on the other side of a fold until you've really seen the proximal edge of it. And that's about all the blabbing I can do about that.
So Doug, just for my sake, I know we only show one picture and that's it, but the question that I have is you inspect it really carefully, do whatever inspection with the NBI and so on and so forth. You're convinced that it's all benign tissue. How much effort do you make to use a big snare and get an en-bloc resection versus a smaller snare, which I agree with you is safer, and end up doing a piecemeal resection?
So if the whole purpose of who benefits, I guess the question, who benefits from an en-bloc resection? Why are we so wild about en-bloc resection? The only people that benefit from en-bloc resection are people that have superficial submucosal invasion, or if now there's some controversy that deep submucosal invasion by itself may not be a risk factor for lymph node mets. But it's a fairly small group of people. I think overall it's a little bit overdone in lesions that are probably benign. But again, so there are times to do it when you really think there's a significant risk of en-bloc resection. I guess the question is the number. Where do you find the number needed to treat? To try to save an operation. I think maybe 10 is about the right number. 30 is probably too high. But there's some differences about that. I mean, you might be able to, that lesion is on the borderline. You could pull it out en bloc with a full thickness resection device if it doesn't go too far on the other side of that fold and get the whole thing out in one piece.
We have a question, and then I'll play the video.
Doug, what about doing this as total underwater polypectomy?
Total underwater is a great idea, especially again when you want to go en bloc, because in the randomized controlled trials, underwater is more likely to give you an en bloc resection. When we inject, we make lesions bigger and make it harder. When we go underwater, they stay small. And so I think especially in the 20 to 30 millimeter size range, and sometimes even maybe 35 millimeters, when you're underwater, you have a chance of getting it out en bloc that's greater with standard conventional EMR.
Doug, would you, there's a study that's coming out from the guys in Germany, I guess, that looked at en bloc versus underwater versus hot snare polypectomy, and the problem is in management of bleeding, I think. And so in large polyps, remember I said with cold snare, you're going to get into bleeding. If you tried to tackle this without cautery, I think you'd be in trouble underwater. If you did it with underwater, you'd have to do it with cautery. Would you agree?
I think underwater almost presumes that you're going to use electric cautery. I think almost everybody doing underwater is doing it with electric cautery. But you're absolutely right that you can't see underwater when the bleeding starts. So they don't go together well. Basically, underwater is really a thermal technique, as I understand it. And it doesn't have to be. You can take things out cold underwater, but when you get into piecemealing and so on, it's going to get hard to see.
Yeah, that was the whole study was actually cold underwater, cold versus hot, and about 25% of the time when they started bleeding, they had to stop and convert. So it just the point about management of bleeding. I was talking about cold snare, this would not be an underwater cold snare.
The question? Oh, yeah, we had a question. I thought we could go with a question, and then I really want to play
What are some of the indications for full thickness resection in your practice?
For use of the full thickness resection device?
Yes.
Well, I think everybody's got sort of a different idea about that, and I think it's going to change if we sort of reach the final opinion that deep submucosal invasion, more than 1,000 microns of submucosal invasion, is not an independent risk factor for lymph node metastasis. In other words, you can have that. So, but I would say I use it mostly for lesions that are going down into diverticula. I know some people, one of the most common uses in the U.S. is patients who have had previously partially resected polyps or have recurrences. And I personally think that that is wildly overdone. You know, there's a 2% perforation rate with the full thickness resection device, and I can get all of those, virtually all of them out with standard techniques, either snare resection and avulsion and burning up the edges and then clipping the site, and none of them perforate. But I do think there's a set of lesions where you want to, they're in the, you know, really above 20 millimeters, it's very hard to get an R0 resection with the full thickness resection device. But I think it gives you a fabulous specimen. It's a perfectly reasonable option for something that you think is a T1 cancer that's 20 millimeters or smaller. And then the other times I tend to use it are lesions that are like, you know, down in a diverticulum, and you can't get them out in any other way. I think it's great. I think hybrid approaches are increasingly going to be okay with full thickness, where you've got a big lesion and you can tell, you know, there's nice 3 changes maybe in one part of it, and you in one session EMR out the part that looks benign and use the full thickness on the last part of it. I think we'll see more of that. Other thoughts about that? Anybody else have any thoughts about that?
No, all good.
Play the video, please.
You would include appendix as well in your.
I personally am not a big fan of the appendix thing. I think you can take people's appendix out, you know, with a little clip laparoscopic operation, and risking a 20% chance of appendicitis seems like too much to me. If the appendix is already out, I think it's great, but I don't fully see the point of it. What do you think? You like appendix?
Standard appendectomy, you don't get the cecal area. It's
yeah, but a lot of
I
know, but it's still it's a clip the end of the. Mm-hmm. It's incredibly important that nobody do a right hemicolectomy for a lesion that's occupying the appendix. But you can get that operation out by clipping off the tip of the cecum, and the patient still, you know, goes home the next day. It's basically like an appendectomy in terms of their recovery. Nice job.
This
Looks
polyp,
good.
thank you. So we used a 15 millimeter snare. We injected, of course, and we used electrocautery for this case, and we were able to remove in 2 pieces.
I don't think that's bad at all. And if you do the snare tip soft coag around the edge, you know, the recurrence rate is, you know, 1.5%, 2%.
Cool. Next slide, please. Okay. Are you able to just flip over to the next slide? AV. So that was going to be my next question.
Oh, sorry.
So you can play the video. So we did do a snare tip self-coagulation. Is this something that you do on a regular basis, Dr. X?
I think this is standard of care. This is the most important thing that's really happened to EMR in the last 2 decades, because you know, there was a hint of it in a study that was done at St. Mark's by Brooker, and it was published in 2002 with APC. But nobody believed it because there were so few patients. There were 21 patients in the study, and the recurrence rate in the control arm was so high. So now we have a randomized controlled trial with this technique, which is very cheap, very fast, did not increase the complication rate, and lowers the recurrence rate from, in the randomized trial, 21% to 5%, and then in a big multinational trial to under 2%. So, and we see now lesions 70, 80 millimeters in size, and if you do this really meticulously around the border, you see very low recurrence rates. So.
Yeah, so that was the randomized trial by Michael Burke in Sydney, so of about 370 patients. The difference in recurrence rate after snare tip soft coagulation was 21 in the non-snare tip group versus only 5%, and this difference obviously was significant with p-value less than 0.001. So now that the polyp's removed, the margin's cauterized, is there anything else you would do, Dr. X?
I would close that site because you're proximal to the splenic flexure. You've used electrocautery, so I would close it with clips.
Okay, so And this is your randomized trial, Dr. Rex. So can you go through the results?
Well, I mean, the study showed, and our trial, which is a multi-center trial, mostly in the U.S., and then a very nicely done trial in Spain, and the meta-analysis of these studies. And then just recently, there's a randomized controlled trial just in the last week or two from Michael Burke's group, which confirms the result that if you're proximal to the splenic flexure, the closer you get to the cecum, the greater the value. Once you get above 4 centimeters in all directions, so it's 4 centimeters lengthwise and 4 centimeters wide, it becomes technically quite difficult to close the full site. But there's a clear benefit, at least 2/3 or higher, in reduction of delayed bleeding. So if you do a lot of this, it makes a significant difference.
Okay, great. That's it. And this was my next video, but I think we're running very late, so are we finishing? Okay. All right, thank you.
All right, I want to thank these panelists. It's been a fantastic session, and thank the audience for staying and enduring with us.